Good morning. I'm really excited that you're all here. I really appreciate having you here in the Giraffe Zone. I just want to warn you that the places have not moved. They will be the same. They just all have new names as of Sunday. So I can't resist with my chairman and with my esteemed colleague, Dr. Hickman, to point out that the River Zone, which we will be part of, is very unique. And as near as I can tell, as I go around and talking to our specialists, the only two groups who really believe the color is exactly right are the urologists and the nephrologists. They believe all water should be yellow. I don't, what can I say? It's confusing and challenging, but nonetheless. Again, the reason for the change is with the new building. The new building is 2 floors lower than this. We are built on a hill. That means we've got to change all the numbers, and somehow being at a minus level didn't sound like the right thing to do. This is another of our Sconyers-Godfrey ethics lectures. Ben will comment that our visiting professor has again had an unexpected event and won't be here. So we have 2 very young people who are going to take over his responsibility. You may have met Dr. Lena Liu somewhere along the way. I think I've seen her here at Grand Rounds a few times. And then Dr. Godfrey is actually going to be 2 people. He's going to be Kyle and himself.
Thank you. Yeah, unfortunately, our speaker couldn't make it at the last moment because of a family illness. And we talked on the phone, and we decided that it was important to go ahead and do the Grand Rounds because this was an important topic. We were going to do it last year at the same time, and we had a snowstorm. And because there was a snowstorm, we thought we should go ahead and do that. So I did have a chance to have a nice conversation with Kyle on the phone. And I will be showing his slides, and we've had a discussion about his slides, and I feel I can do a pretty good job of conveying both what he would have said as well as some of the things I also would want to say about this topic. For those of you who haven't been here before for one of these ethics Grand Rounds, let me try to describe briefly what the format is. These Grand Rounds are based on a case. The case is not necessarily an actual case, but an amalgam of cases to sort of describe a situation. We begin by having somebody from Seattle Children's present the case, as well as providing a brief amount of information about the background of the issue. And then we follow that with a commentator who will usually talk for 10 or 15 minutes, presenting their perspectives on this. And the key part of the Grand Rounds is having the discussion afterwards, which we try to leave a good half hour for. And we have microphones on the aisles, and the reason why we do it that way rather than the single microphone is so that it allows the people who are talking, as well as the people who are responding to questions, to be aware of who else wants to speak, and allows us to sort of modulate that time better. For the discussion, both myself and Lena will be participating co-equally in answering questions and engaging it. A few other quick announcements. As Tom mentioned, this Grand Round series is supported by a fund by Jeff Sconyers and Deborah Godfrey. Our next Grand Rounds will be on May 16th on the topic of parental refusal of organ transplantation. Also coming up this summer will be our 9th annual Pediatric Bioethics Conference. We typically do our conferences on a specific theme, and this time our theme is a little different from other themes because it's a broader theme. It's on cases that keep us up at night. So it's an amalgam of all the complex ethical cases that we've addressed over the years that we feel like even after we've solved them, we're still not satisfied. And so it should be a fascinating series of presentations and discussions for all those of you who have been there before. It should be great. For those of you who haven't, I would encourage you to come. Registration just began a couple days ago. Before I introduce Lena, I want to say one more word about Kyle Brothers, who won't be with us today. We had been very excited for Kyle to come because Kyle is perhaps the only person who I know who is a pediatrician who runs a weight loss management clinic and also is focused on bioethics. Kyle trained at Vanderbilt University. He did his residency and his fellowship, and actually will be completing his PhD in religious studies from Vanderbilt this coming year. This past summer, he moved to the University of Louisville, where he also is running a weight management program there as well. So Kyle has the experience of these programs in both Tennessee and Kentucky. And it's unfortunate he couldn't be with us. Lena Liu has been in the department for over 15 years, and she has been at the Odessa Brown Clinic primarily. And she also is very involved with the weight management programs here, and she'll be presenting the case today. So let me go ahead and turn this over to Lena and for the case presentation. See if that works. Oh, I was already on, never mind. Okay, Lena.
Okay, good morning, everybody. Thank you, Benjamin. So I hope that this case, resonates with a lot of you. I know that it did for me. I have certainly seen kids like this within my own clinic, both at Odessa Brown and within the weight management program here. So Damari's an 11-year-old boy who comes to you in your clinic for a well child check. His weight is 200 pounds, which is about 91 kilos. He weighs, he is 5'1", has a body mass index of 36.6, and when you plot him on your BMI growth chart, he's at the 99th percentile for his BMI. There's a strong family history of type 2 diabetes and sleep apnea in his family, although he has neither of those conditions right at this moment. In social history, he lives with his single mother and sister in an apartment complex. The family does not feel that there are safe places to play outside or parks nearby where they live, and he receives assistance for food and housing. So what I'm going to go through is his story, and while I go through his story, I'm going to share with you some of the different clinical programs and resources we have here at Children's, which he participated in. So in 2007, Pediatrics published some expert recommendations on obesity prevention and management, and they proposed a staged approach, 4 stages of treatment going from primary care to tertiary care, and that progression in these programs depends on availability of these programs, family motivation, and the degree of obesity that the child has. So when he was in his PCP's office, he or she did a medical evaluation, and the recommended labs to do in primary care for a child who's obese are the fasting ALT and AST to look for fatty liver, a lipid profile to look for hypercholesterolemia, and a blood sugar to look for type 2 diabetes. And all of his labs were normal. He was then referred to the sleep center because he had some snoring history, and he was found to have sleep apnea and required BiPAP at night. His PCP also referred him to a nutritionist to be seen every month to 2 months for counseling on healthy eating and activity. And there he was counseled to decrease his soda intake and to decrease his screen time. Not surprisingly, the family had difficulty making some of these changes, so the PCP referred Damari and his mom to the ACT program at the local YMCA. The ACT program stands for Actively Changing Together. It's a joint program between Seattle Children's and local YMCAs. We started in 2004 here in the greater Seattle area and have now expanded to 3 counties, including now reaching out to Yakima. We are in 15 branches, 3 counties, and the Yakima program and some of the Seattle programs actually are also in Spanish. This is a healthy lifestyle program for kids who are 8 to 14 years of age to be accompanied by a parent or guardian from their home. It meets once a week for 90 minutes, and it lasts 12 weeks long. We're offering it twice a year, usually in the beginning of the year, starting in January or February, and then again, another program starting in the fall. And there's the website to access the program. So Damari continued to gain weight despite trying to do all these things, and at age 14, he weighed 330 pounds. So he had gained 130 pounds in 3 years. He was 5'4". He now had a BMI of 56.2, and his sleep apnea was worsening. So his PCP then referred him to our adolescent wellness clinic. So let me tell you a little bit about that. So the ACT program sort of fell under stage 3. So after the PCP intervention and general counseling in the primary care office, the second stage is working with a more comprehensive program, potentially in the community or within a primary care clinic. Stage 3 is called a comprehensive multidisciplinary intervention. And we have clinics both for children ages 2 to 11 and adolescents. And these are clinics where we see families both on an individual basis, but we also have group classes. Our teams include a medical provider, a dietitian, a social worker, and a fitness specialist. And we meet with the families pretty intensively. In the Child Wellness Clinic, we meet with families about every 2 weeks for 4 months. The counseling method we use is grounded on motivational interviewing. And if you look at the time that we hope to have with families in, for example, the Child Wellness Clinic, it exceeds the U.S. Preventative Services Task Force recommendation for moderate intensity programs. So let me spell that out for you a little. The U.S. Preventative Services Task Force for many years was not making a strong recommendation to PCPs to do anything about obesity, including screening. But they changed their tact in about 2010 and said that they did recommend that primary care docs start screening for children, screening for obesity using BMI and BMI percentile. And then for children who are motivated and also high enough risk that they be referred to moderate to high intensity interventions that incorporate nutrition, physical activity, and behavior counseling. And these programs were defined as having more than 25 hours of contact over a 6-month period. So what happened to Damari? Well, despite participation in these programs, he continued to gain weight, and the family was really struggling to make significant health behavior changes. And there were some notes from the social worker who saw him in our adolescent wellness clinic. He had moved into a new apartment with his mother and sister, but there weren't enough beds for all 3 of them. He had been living in a 3-bedroom apartment with 17 other family members prior to that. And from her note, it said that they were in an overcrowded and chaotic home environment. He did follow up with all his medical visits, despite not being able to make the health behavior changes. And then one other significant thing that was noted in his social history was that they had food insecurity. And food insecurity is a term which means that families have difficulty accessing healthy food, enough food during a period of time and go hungry. And we are seeing this paradox of both obesity and food insecurity in many families, low-income families these days. So that was a huge challenge for them. So does any of this ring true for some of you? You've seen cases like this? So some of the questions that this case brings to mind are, is it appropriate to make a referral to CPS? Under what circumstances would a referral be made? How important is it the availability of effective treatments for the child or adolescent, for the family, for the environment? Which harms or risks are pertinent to the decision to make a referral, and what is the goal of making such a referral? What alternative strategies might we consider for Damari? And would it ever be appropriate to remove a child from a home because of obesity? And I'm sure you've seen some of the cases in the news where that exact thing has happened. So I'm going to hand things over to Benjamin to discuss the ethics.
Thank you. Thank you, Lena. Before our session began, Lena and I were chatting, and she says, boy, you know, I know how to handle these patients, but the ethical issues are pretty complicated. I said, yeah, you're right. And I also said that part of what we do in ethics is not so much identify simple answers, but try to uncover the complexity and the nuances and the subtleties. And when I was having my conversation with Kyle yesterday discussing his slides, it was very clear to me that's exactly what he's trying to do in his comments. And in fact, there's really 4 points that we would like to make. And from now on, I'll be saying we, which refers to both myself and Kyle. So I'll be channeling him and channeling myself. The first is talking about some of the complexities of what is meant by medical neglect and how interventions like CPS can be helpful. Trying to think a little bit more deeply about obesity and what it means as it relates to health. Describe a couple of scenarios from Kyle's experience in his clinics and show some of the differences of how this can manifest itself that augment the case that Lena presented, and then acknowledge some of the challenges in spite of all this, trying to resolve these. So when we think about medical neglect, conceptually we're thinking about actions that the parents may take or not take that result in a child not receiving the benefits of particular medical interventions that result in medical harm. And in a very simplistic way, when we see this occur, we can make a referral to CPS, and the idea would be this child could then, if it met that threshold of causing a serious and reversible medical harm, the child could be removed from the home, put into foster care. In theory, then, the child would receive those appropriate medical benefits, the treatment and the benefits. And that's how it's supposed to work. We'll talk about some of the challenges with it, but one of the points we want to make is that this is not the only reason for engaging CPS. CPS has a range of approaches it can take trying to achieve medical benefit. It's not simply an issue of removing a child from the home. In some cases, CPS can be effective in helping the family achieve certain types of support that they may benefit from that will allow that treatment to be provided and the benefit to occur. In other cases, they may be able to motivate the family in a way that they haven't been motivated before to do certain actions. Now, these are all speculative, and it really depends upon the family. It also depends upon the approach that a particular CPS unit would take, and therefore it requires a lot of communication between healthcare providers and CPS. But the point here is to show that the notion of a CPS referral could have a range of possible reasons for doing it. And finally, we also can still ask, are there other alternatives prior to CPS that may be less harmful? And we heard from Lena with regards to various stages, are these various attempts at escalating the extent and level of care prior to CPS. One final caveat is that it's not necessarily the case that a referral to CPS and a placement in foster care would necessarily result in weight loss. And that's one of the challenges, is that we believe it will help, and it can help, but it's not guaranteed to help. So the next point is really this distinction of obesity as a health outcome versus obesity as a risk factor. And as a health outcome, the idea is that there are many factors that result in children being obese. And this is a slide that Kyle shared with me that shows that in the middle, are not in the middle, but in one of the circles are the parental styles and family characteristics that really have an influence on children's obesity. But you can see there are also characteristics regarding the child themselves, as well as a broad range of community, demographic, and social characteristics that, particularly in the last few years, we've had increasing attention to these social and environmental determinants of obesity. Here's another slide that also tries to illustrate the same concept. If we think about obesity as an outcome, there are the factors that result in that include ones at the work and school level, at the community level, at the national level, even at the international level, before we get to the individual. And so while the individuals are critical in the final outcome, there are many, many factors that also have an influence on this. And so this is illustrating the complexity of the environmental and social factors. What's also particularly challenging is that both scientifically and particularly as portrayed in the media, obesity as a health outcome is often portrayed as a biological problem. And as there is research describing the genetic contributions to obesity, these are the ones that often attract a lot of attention and also further complicates how we think about obesity. And here's a quote from that. Weight loss scientists say they believe that once more people understand the genetic and biological challenges of keeping weight off, doctors and patients will approach weight loss more realistically and more compassionately. And so while there's maybe some truth to that, the question is how do we think about that concept in relationship to these other environmental concerns? But rather than only thinking of obesity as a health outcome, we can also think of obesity as a risk factor for other conditions. And we can also distinguish between obesity as a risk factor for diseases themselves and obesity-related health behaviors that result in a variety of diseases. And I'll illustrate that more clearly in the next slide. So obesity can be a direct risk factor for things like obstructive sleep apnea based upon the complex factors that we know result in obesity. However, for things like diabetes, hypercholesterolemia, coronary artery disease, it's the behavioral lifestyles and the behavior activities that are the risk factors for that. So it's a poor nutrition, it's the lack of exercise that result in physiological changes, regardless of whether you're obese or not, that result in those problems. But as you see here, there is an interaction between them. And the point is that we should really be focusing on those lifestyle activities and the risk factors that that poses for the child in a variety of ways. And in that regard, we can then think about the parental behaviors that may have an impact on those lifestyle choices. So there may be a variety of behaviors that parents can do that will directly impact the health practices of their children. They can look at what types of foods are available to drink in the household. They can look at how they purchase food when eating out. They can ensure that children can get to school and community-based activities to be more active. They themselves can be engaging in physical activities with their children, monitoring what's happening at school in terms of food, and restricting access to the media that may also complicate healthy choices. So this is really focusing on the parental behaviors that can have an influence on risk factors for obesity-related disease. So let me now describe two different cases that augment the case that we heard about from of Damari. We have got Camion and JL. Camion was a 16-year-old who was followed in a clinic for 3 years. His family was well liked, but they were believed to lie often about their behaviors. The family was socially and financially stable and appeared to be motivated. JL had only been at the clinic for less than 6 months. His family was not liked by the clinic staff, and it may seem like an odd thing to be talking about whether they're liked or not, but as we all know, one of the challenges of caring for families are the relationships that we engage with them. And relationships can be a double-edged sword because, in fact, liking a family can be good or bad in the way that it makes us see or not see what's going on. In this case, there was obvious family chaos, and the family admitted to a lack of motivation. So very, very different descriptions of these families. So with Camion, he was admitted twice to the hospital, both times with significant weight loss. CPS had been contacted, and a detailed treatment plan was developed over 2 years that he was following. In spite of that treatment plan, his weight ultimately reached up close to 600 pounds. He was no longer ambulatory, and ultimately, he was removed from the home by CPS. This took 5 years. JL, when he was at the clinic, he had rapid weight gain across just 2 visits. It was clear that there was a lot, and this was a functional disability. He had no subsequent complications in terms of obstructive sleep apnea, no diabetes, but nevertheless, CPS was contacted, and he was removed from the home much more rapidly. Now, what these 2 cases illustrate are different ways that CPS might have been engaged with these families. In the case of Camion, we knew that the interventions in terms of food would be effective. And over time, he was continuing to be followed, and because his family was not following through with the specific recommendations, he was removed from the home. Because this family was well-liked, things took much longer because of this idea of fostering this relationship. In JL, obesity was not his main problem. It was really a functional disability that was a symptom of a much more severe family dysfunction. In this case, the self-report about the lack of motivation was important, but it was really the issue was really less about the weight as much as about the family dysfunction. Now, what I think is interesting is that there's a lot of dysfunctional families, and I think as we saw from Lena's case, it's often unclear if we removed every child from every home that's dysfunctional, we'd have a real challenge. So, I think this is one place where I think Kyle and I diverge a little bit, is knowing how do we deal with this issue of family dysfunction as a justification for CPS and for removal from the home. I think it's much more complex. The last point that we'd like to make is that if we think about opportunities for contacting CPS, is to not say we're calling CPS for obesity. We're removing a child from the home for obesity. It's something different from that. We're removing the child from the home because of the parent's unwillingness to engage in certain behaviors. And we can think about families either being in several categories. There are some families who are willing and able to accomplish these goals. There are some families who are willing but unable, and some who are just unwilling. And it's really those families who are unwilling where the issues are the most severe, the most critical. And so he would reframe this as calling CPS for harmful family dysfunction effects on the child manifesting as obesity and other things. I think it still raises the question in my mind about what level of family dysfunction is sufficient for engaging with CPS, although I think part of the answer will be related to the resources that a particular CPS group has to use. And ahead of time, we had some conversations with some of our colleagues at CPS to ask them to be able to be here with us for Grand Round. So we'll also have an opportunity during the discussion to hear more about their thoughts about how these issues and what sort of resources they have to help us with these. So let me end for the discussion by making one final comment about the challenges of trying to use the healthcare system to make decisions about referral to CPS and make decisions about managing obesity. And so here's the last example that Kyle provided for us, which is a 14-year-old who lives with a family in a very isolated area. He's greater than 400 pounds, which has been normalized by his family. They come for the first clinic visit. It's very tense. And the mom acknowledges that the goal is to prevent a CPS call. They come for this one visit. They show up. And then they're gone. Lost to follow-up. So it's difficult for these providers, at the one time, to really engage with a family and have a relationship with them. And so the idea of flying under the radar is simply that if families haven't formed a relationship with a particular set of providers, it makes it much more difficult for those providers to make decisions about when other interventions are necessary. So in this case, even attending this visit kind of was not sufficient for the family for the providers to have a relationship. The other challenge is that we often listen to what the families tell us about what's going on, trying to assess what's happening. And that also can be a challenge because unless we have a good way of understanding what's going on, it's difficult to make decisions. So with those comments, actually I'll make with those comments, let me end. These were actually the various people that Kyle wanted to thank who are part of the weight management program at Vanderbilt, as well as some of his mentors there. And Kyle will be back at some time, and I'm sure you'll have a chance to meet him at a future Grand Rounds. But let me invite Lena to come back, and let's open up this for questions. People, it takes a while for people to.
So, Chris Campbell, one of our former residents, who's now a child.
I think you have to turn the microphone on, please. Yeah.
Thank you. Chris Campbell, one of our former pediatric residents, who's now a child abuse doctor in Utah, published an article in that best pediatric journal last year, talking, and they went back and looked at kids reported to CPS. and look at what services were provided. And basically, the answer was none. So, I think that has to be taken into consideration when we look at reporting families to CPS. What do we really, A, want them to do, and B, expect that they will do?
Yeah, no, I think that's a very important point. What I'm curious what I haven't read that paper, but certainly my understanding, at least depending upon the location of CPS and the resources available, there are resources that can be provided. So when they say that there were no resources provided, that they just didn't, it was like nothing.
Basically, the kids and the families did not have the resources that you would think that CPS would provide in this follow-up study on kids that were reported to CPS.
Okay.
I sort of got the message that the resources provided weren't effective.
Can you hear Mike?
Yeah, the CPS had provided some services, but the services that were provided were ineffective in changing the families that had been referred.
So I'd like to make a slightly different point. In the state of Washington, at least, it's a requirement for those who are licensed clinicians to report when they have reasonable cause to believe that abuse or neglect may have occurred. Thank you, Dr. Pendergrass. Yeah, right, okay. So physicians must report to CPS when they believe that neglect has occurred. Now, the question I think you're raising is whether the constellation of factors around obesity actually constitute neglect or not. Now, neglect is a defined term under the statute, at least for legal purposes. This is a place where law and ethics intersect, perhaps with a handshake, but not with a close personal relationship. But at least for the purposes of this discussion, people need to be aware that if they form a conclusion that the parents are neglecting their child by not doing the things that you consider to be reasonable for them to do, if that constitutes neglect, they have to report to CPS. Whether, in fact, as Fred points out, CPS actually has tools available to help them or not. They risk licensure action, and they risk potential claims by injured parties if they don't do that. Not that that makes a lot of sense, but there you go.
Well, Jeff, thank you. In fact, actually, Kyle and I had a fairly detailed part of our conversation was very much on that point. And I think, like you, part of the issue was exactly that notion of whether these things constitute neglect. But part of our conversation also was that even while there's an obligation to report once that threshold is made, if in an idealized way, if CPS had the resources to function in certain ways, even when it's unclear that that threshold has been met, if that was a way of providing resources that were effective, that might be a very useful thing. In fact, Kyle actually shared with me a conversation he had with a family about whether he should make a referral to CPS, because that would be a particular way in this environment where certain services that they were otherwise not able to get, but they could get. So it can be a much more, there's a complexity to it, but obviously I would agree that once that threshold has been reached, we do have that obligation. Please.
I wanted to say something too. I think the other thing that I've looked at, I think in Damari's case, and actually I have personally a case that I've struggled with at Odessa Brown, is the distinction between some behaviors that help a child's health, such as going to subspecialty appointments. And both in the case of Damari and the child that I took care of, Odessa Brown, the family was pretty good about following up with medical care. So making that distinction from health behavior and lifestyle changes, which how many people in the room have tried to be on a diet before? Look at the obesity epidemic right now. The changes that we're asking people to do to try to decrease weight in these children are very, very, very difficult. And there are different degrees of motivation that families can be at and different amounts of readiness that they can do. And if you talk to adults who've successfully lost weight over time, they will tell you that they have completely transformed how they live. They eat differently. They think about their eating differently. They've changed their activity throughout their day. We're talking about really transformational changes that people make to reduce their weight, because we're in this culture where everything around us is, helping us gain weight. So you can make those changes, and we can encourage families to make these changes, and then we throw them back out into American culture where nothing supports that. So I think that it's important to look at, when I've thought about these cases for myself, I've had to pull those two groups of behaviors apart. That is, those that were supporting the child in their medical care and those that were around the weight, because I think that to me, they are very different in terms of achievability.
Hi, I'm Jeff Norman, and I'm the CPS program manager. And I wanted to talk about what happens when you make a report to us. And so if it does meet that legal definition, in this case of neglect, then that is screened in for an investigation response. And a worker is assigned, and then that worker is going to use specific tools to try to determine whether we have a safety threat on hand. And we have a practice model, and it's called solution-based casework, which is very much focused on engagement with families, partnership with families, trying to come to consensus with families around services that may be needed, developing case plans. And even though we are in an investigative mode, we find that the more that we can engage families, the more that we can work with them as a partner to help them deal with an everyday problem that has really reached a point that it's exceeding over into a safety threshold issue, that we can be more successful, and they're less likely to return into our system as a re-referral. So in the matter of how do we respond to a situation of a child who may be grossly obese, we would rely very much on healthcare providers, and we want to help engage that family in conversations with you, team with them, and help to bring it back into Seattle Children's or some other healthcare system that's trying to deal with the family. If the lack of response or the unwillingness from the parents to help the child be in medical care and to help the child lose weight to the point that a child's life is really threatened by this. If we have a specific safety threat that we don't believe can be managed in home, then that would bring us to the point of deciding to place a child outside the home. And that could be done on a voluntary basis, at least for a short period of time, or if necessary, we can go to court. We have the authority to file what's called a dependency petition with the court, which is basically going before the court and alleging that a child has been neglected in this case, and or there's no parent that's capable of providing safe care for the child. And through that process, it becomes much more adversarial. Families have they have a right to counsel. It's very often public defender, and it can be a game changer in lots of ways. Not necessarily for the best. I think cases that come to court are those cases where we've had the least ability to engage and resolve matters with families. However, in those situations, then a child could be placed in foster care, but I think that the whole focus of this would be, again, to strongly focus our efforts on getting back into this healthcare system and helping to make changes so that the child is beginning to lose weight, because by ourselves, we're not healthcare providers, and this is such a complex question that I think the only way that we can be effective is to have a very strong tie with with you or with other healthcare providers to affect that change?
Let me just respond briefly for 1 second. Thank you for those comments. And I think what you underscored was that notion of the part of at least ideally a partnership being between CPS providers and the family. And I think that the challenge sometimes, though, is that while I believe you articulated what I would also endorse as what CPS ought to be, one of the challenges, and Jackie's here so she can respond to this too, is the public perception of CPS and the family perception of CPS. And how do we overcome that initial perception so that the families also will see what we're articulating as the ideal goal? I don't know, Jackie, if you have any thoughts about that either.
Thanks, Ben. I'm Jackie Brand, a clinical manager of our hospital protection program here at Children's. And I just wanted to say two things. Our program includes our medical director, Becky Weister, and Ken Feldman, and a number of other social workers. And I want to just make sure that everyone here, and then spread the word for sure, knows that we're a resource. So if you're in this situation as the medical provider, seeing this child and kind of, sort of walking this line of, should we call CPS, should we not call CPS, is this a neglect issue, is it not, what can we expect from CPS, please call us. We're extension 72194. We want to be a resource. We want to be a resource to you to think through that. I mean, we may not have the answer, but we're happy to give you another point of view because we work with CPS all the time. And so we have a level of knowledge, as Jeff Sconyers was saying, what your mandated requirement is, and also what to kind of expect from CPS. And so if and when you decide, yes, you will be making that CPS referral, we will provide that support to you throughout that process. And we can also offer setting up a multidisciplinary team meeting to bring in CPS and sit down at the table with those providers that know this child the best and know what avenues you would like the child to take and the family to make the changes to be healthier. So again, the front end, and then once the response referral is made, we'll stay involved and help support.
So Jackie, are you saying that you would help set up a conference with
Yeah.
CPS even before a CPS referral is
No.
made?
No, once you make the
Okay.
CPS referral, then we'd set up that type of decision-making and discussion. But I'm saying our team, our hospital team, can be a resource to provide you some how to think about whether you're at the point of your mandated requirement to report to CPS.
Yeah, and I just want to underscore that because I think, Jackie, what the critical point here, and it relates to Jeff's comment, is that rather than worrying about whether you've reached that threshold or not, even when you're just thinking about, sort of like thinking about a spinal tap, that's perhaps a time that you can actually engage with your team and have further conversation and collectively make that decision whether it's reached that threshold. Yes.
So, I mean, I'd just like to echo how important it is to be in an alliance with CPS and social workers, because I think that we have to fully appreciate the limitations that we have as providers in understanding the full story and the full picture of these families. I mean, it takes a certain level of cultural competency that extends beyond, I think, what we can see in an office visit and when we're following them, and often the changes or the barriers that need to be reduced are often out of our purview. And so I just feel like there's kind of some kind of parallel assessment that's, obviously going on as you're assessing this issue of neglect, because they're so intertwined. I mean, it becomes relative to think, I think then of what constitutes neglect depending on what kind of psychosocial situation these kids are coming from.
I in no way want to denigrate the conversation that's happened, but I want to go back to your original case. It's pretty easy for me to make that decision, I think, for that 400-pound 3-year-old or that 600-pound 12-year-old. But the 200-pound 12-year-old is more challenging for me. And I want to come back to the access to resources with the Y, with our obesity center, and get some more guidance about what should we be doing with that child whose glucose is fine, ALT/AST is fine, GGT is fine, but this kid's obviously at the 99th 99th percentile in weight. We have the conversation, your weight's out of control. In my case, maybe we're making it out of control with some steroids on top of all that food insecurity. Help me, where do we go with that?
That's a great question. I agree with you, Tom, in terms of the severity issue and how I think the cases that we're discussing here that might go to CPS are really the very, 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 very tip of the iceberg, and they should be rare. And when I think about Damari's case, I actually think that when we were preparing this grand rounds, Damari actually had been referred to CPS. But going back to your question, that's a very difficult one, Tom. I think that we can only do what we can do. And I think that it's really important, as that other woman who just spoke said so eloquently, that we really need to build relationships with these families. And for me, that's really the fundamental piece. And fortunately, I'm a primary care doc, so I have the luxury of getting to build a relationship over time with these families and really getting them to trust me. I think the fundamental, I think a lot of this work really rests on trust and a lot of transparency with the family, but it takes a great deal of time to get there. So that's the very, very first thing for me is building a relationship. And then for families that you see over time, I would say starting early as possible, as early as infancy, to start counseling in primary care. And then once you get to school age or adolescence where there's definitely obesity present, I just engage the families as much as I can when they come in to see me, to see whether this issue is even on their radar screen. For some, it is, and they come in and that's exactly what they want to talk about. But for many of the families I see at Odessa Brown, they actually have other broader issues that they're struggling with. The kid doing okay in school, mom keeping a job. I have families where both parents are working and they're opposite schedules, and there's just so much stress in the home that this is not the top thing on their radar screen. And so for them, I just sort of keep that issue in the back of their mind, in my mind. And when they come in and I kind of assess the situation, if I see an opening, I'll put it in. But I have to look at the whole big picture for the family. Yes, we do have resources available. We're trying to grow them so that we have more resources available to parents. But with this obesity epidemic, these programs are not going to solve the problem. And so really our mission in our obesity program here is also to be looking at policy and looking at environmental changes. Ultimately, that's what's going to make the difference for this issue. And so we work with a statewide policy coalition to make changes in our state and local regulations, food label menuing, safe routes to schools, looking at food and physical activity in schools, linking messages between the clinic, child care centers, schools, so that families are hearing consistent messages from their entire environment. It's really pairing a little bit of what we're doing in medicine with this broad environmental change that is needed.
Great. Any final comments? Lena, I think your last comment was a great way to end, because I think you really hit the nail on the head. So thank you all very much. And that was good.